Well, hello there, and welcome to the series finale of Are We There Yet? I can't believe we are at the final episode. And by the way, before we take a listen, can I just say a massive thank you for all of your comments and all of your feedback on this series, my first ever podcast. I'm genuinely bowled over by the response. But look, we have had some amazing guests, everybody from Elizabeth Day to Trini Woodall, Leo Varadkar, Cecilia Hearn, Samantha Mumba, everybody. And I've just really enjoyed the conversations, and I'm glad that you're enjoying them as well. And we are already thinking about season 2. We have already secured some big names. Can't reveal anything yet, but will do very soon. And actually, on that note, who would be your dream guest to listen to on the Are We There Yet podcast for season 2? I'm all ears. Let me know. So today, for the final episode of Are We There Yet? I am chatting to a woman who is leading the way in cancer care in Ireland, Dr Lorraine Walsh. She has dedicated her entire career to advancing cancer treatment in Ireland, specifically breast cancer she specialises in, gynaecological cancer and lung cancer. And honestly, it's a word that none of us want to hear, but it's a word that none of us can escape from. It can be very overwhelming, whether it is you that's been diagnosed or somebody close to you. And I have to say, chatting to Lorraine, she is a voice of reason, and her bedside manner, I came away going, God, I wish she was my doctor. She is so insightful, so informative, and you know what? Very hopeful about where we are in Ireland at the moment with cancer treatment. So I learned so much from this conversation, and I really think you will as well. And as I said, hope at the end of the day. So hope you enjoy it. Dr. Lorraine Walsh, it is so lovely to have you in the Are We There Yet podcast studio.
Thank you, Kathryn. Lovely to be here.
So you are a radiation oncologist, and we are going to get into what that actually is. But maybe just let's get to know you a little bit. I know you studied in UCC, that you trained all over Ireland, that you did a lot of your training in Canada as well.
I did.
You're a Limerick lass?
I am.
Yeah?
Yeah. Although I'm living in County Clare now, so I suppose I better support County Clare, just on the border. But I work in Limerick, yeah. So I did my secondary school training in Limerick, and then I went to UCC, to the medical school there, and I was there for 5 years. And I did my initial, I suppose, intern year and senior house office years in Cork. And then I moved to Dublin. So I was in Dublin for, I suppose, nearly 10 years, working in St. Luke's Hospital. And then I went off and I did my further specialist training in Toronto then, and then came back to Limerick as a consultant.
Okay, so when was it oncology for you? When did you know, when you were going through medical college, what was it about oncology?
So I always loved, when I was in secondary school, I always loved maths and physics. They were probably my favourite subjects. I did well in them in the Leaving Cert, always found them kind of straightforward. But yet I always wanted to be a doctor, always, ever since I ever remember, I always wanted to be a doctor. So when I was doing my senior house officer years in Beaumont Hospital here in Dublin, I was working for one of the medical oncology consultants. So they deliver the chemotherapy side of things, Dr. Grogan, Liam Grogan. And I one day I said to him, I'd love to do oncology. And he said to me, Lorraine, you should do radiation oncology, because that really kind of was a very good kind of oncology career to be in, but it also really, really has an emphasis on maths and physics. So it just kind of worked out well that way. So I kind of got to do the maths and physics and the medicine at the same time.
So you combined the two.
I did, yeah.
So on a day-to-day basis, what does a radiation oncologist's day look like? I mean, I suppose it depends, obviously varying from case to case, but generally, what are you at?
So I mean, it's not very much mathsy now anymore. I mean, a lot of that is when you're doing your training so that you understand the concepts of how radiation works. But my job as a consultant radiation oncologist is to treat patients who have been diagnosed with cancer. And we use radiation to do that. So radiation uses these very high energy X-ray beams to target tumours very precisely, and at the same time avoiding the other organs nearby. So when patients come to me, they have already had their diagnosis of cancer, and I meet with them and I discuss with them what the recommended and optimal treatment is for them, and I judge whether or not they're suitable for the particular form of treatment, or maybe less treatment is more appropriate. And then we design their radiotherapy and we deliver their treatment then over a couple of weeks, and we monitor the patients during their treatment. So, it involves seeing the patients as they're going through their treatment. And then once patients have completed their treatment, then we have what we call our follow-up appointments with patients, where they come back to us, they've finished all their treatment, and we make sure that they're recovering, and we're assessing how well they've responded to their treatment. And if they need additional tests, we arrange those. And, a lot of patients then reach the 5-year mark where we discharge them and they go on their way.
You specialise in breast cancers, gynaecological cancers. I know lung cancer is an area that you specialise in as well. But if somebody is diagnosed with a breast cancer or a gynaecological cancer, when it comes to picking the right treatment, how do you know whether to go with a chemotherapy or a radiotherapy?
So,
what are the options out there? An immunization therapy as well as another one?
So the good thing about cancer, and as well,
there is something good about cancer?
So the good thing about it is that it's very much evidence-based medicine. So the treatment that you would have here in Ireland for a breast cancer is going to be pretty much the exact same treatment as you would have over in the United States, as you'd have in Australia, as you'd have in other places in Europe. So it's very much driven by the evidence. So the evidence for how best to treat certain cancers is determined by clinical trials that have been conducted on thousands and thousands of patients in order to question and find out what is the best way to treat that particular cancer. So it's not that I pluck something out of the sky and say, oh, this is what I'm going to choose for you, and I'm going to choose something different for someone else. We all treat cancers in the same way. So we all do the exact same thing for the patients, as long as the patients are well enough. So for someone who's just been diagnosed with breast cancer in Ireland, obviously the first thing that happens is they get their diagnosis in what we call a triple assessment clinic. So that's where the patient goes and they have their diagnostic tests performed, such as a mammogram and an ultrasound and a biopsy. And then their case is discussed at a multidisciplinary meeting. So that kind of draws on what you're asking me, in the sense all the disciplines who are involved in the treatment of that particular type of cancer are at this meeting every week.
Okay.
And we all make a recommendation and we all have to agree that this is the most appropriate patient for this particular woman with this particular stage of breast cancer, for example. So if someone is diagnosed with an early stage breast cancer, then we will all agree. So the surgeon, the radiation oncologist, myself, and the medical oncologist, we will all agree that the most appropriate treatment for that patient is surgery first, and then radiotherapy afterwards. And then, if indicated, the patient will also get chemotherapy. So it's very much driven by protocols and evidence.
Okay. And you see, this is why I wanted to have you on the podcast and wanted to talk about it, because thankfully, and touch wood, I haven't personally experienced any sort of a cancer diagnosis. And for people who have, they will be very aware of the whole process that you've just talked about. But for those of us who haven't and who are in our 40s, 50s, 60s, I think it's really good to have these conversations, that we are made aware, because I think if it hasn't impacted you, it can seem really scary and really overwhelming. If it has impacted you, of course it is as well. Yeah. But I think just to break it down and kind of understand the treatments that are available, understand there are first-class treatments available, and understand as well the survival rates when it comes to cancer nowadays. I was reading this morning that 65% of people who are diagnosed with any sort of cancer are living 5 years after their diagnosis, which is up 20% from a couple of years ago. So the survival rates, first of all, if we can focus on the positive, I suppose.
Absolutely,
they are good.
They are. I mean, Ireland is actually performing very, very well in terms of survival rates from cancer. You know, if you compare it against the data all around the world, we're actually doing really well.
Really?
So we're in a really hopeful place here in Ireland. We hear a lot of negative stuff about the health service, but I would say that cancer treatment, for the most part, is really, really good here in Ireland. And we have, I suppose, the government and the HSE have invested a lot of money in the last 20 years or so, ensuring that we have proper networks and pathways, so that no matter where you are in the country, you will still access the same care. And that care is the same care that you would get as compared to what you would get somewhere else around the world. So it's as good.
As good.
So the survival rates for sure have improved. Part of that is down to the fact that we have screening programs where we're diagnosing cancers at an earlier stage, and then the treatment is, I suppose, less invasive. It's easier treatment, and the prognosis, if it makes sense. If you pick something up at an earlier stage, usually that means that you're more likely to be cured from the treatment and less likely to need more complex treatments as well.
Okay. Well, you hear or you read in the papers or magazines or on the radio or whatever that like there's been a big rise or an increase in colorectal cancer or breast cancer or whatever. Is that because we are diagnosing more or we're detecting more? Or is that because there's a kind of a rise in cancers anyway?
So it's both.
Okay.
It's both. So we are detecting a rise in the number of breast cancer cases for sure. Part of that is down to the screening program where women are invited for a mammogram. They don't have any symptoms. So you're screening the well population, and you find these incidental findings in those ladies' breasts, which turn out on biopsy to be a very early stage breast cancer. And in some cases, it's not breast cancer yet. It's almost breast cancer. It's a thing called ductal carcinoma in situ. The other reason why we're detecting more cancers is because we have an aging population. So generally, not always, as we get older, we are more at risk of getting cancer. Not always. But then there does seem to be also an increase in the number of cancers that are being diagnosed in people aged less than 50 at the moment. And that's not really the screened population. So we screen people usually when they're over 50. So these are people now who have never gone for screening. So we do seem to be seeing a kind of an increase in the number of colorectal cancers in people who are less than 50 for sure. There's lots of kind of explanations as to why that might be so. I suppose a lot of people suspecting this probably related to the Western diet, the obesity issue that we have, and the sedentary lifestyle. But it's difficult to know, to pin it down on one particular thing.
It's hard, isn't it? I mean, how many types of cancers do we know or diagnoses are related to lifestyle or related to environmental?
Yeah, a lot
issues.
A lot of cancers are related to those risk factors. No one. I mean, we know smoking causes lung cancer. We know smoking causes head and neck cancers. I suppose about 1 in 10, maybe 1 in 12 cancers are related to excess alcohol consumption. We know that, as I said, the Western diet, which, where we consume a lot of ultra processed foods, a lot of red meat, a lot of salt, are probably also increasing that risk of cancer, particularly colorectal cancer and possibly breast cancer as well. So I would say maybe like you'd read approximately 40% of cancers that are diagnosed are related in some form or another to those risk factors.
Okay. And then where does genetics come into it?
So approximately, talking about breast cancer, approximately 10% of breast cancers are related to some form of genetic predisposition. So that's why when we are first meeting patients with a diagnosis of breast cancer, we always are very interested to know about that patient's family history. To see if there are any other breast cancers or ovarian cancers or unusual tumours, maybe in some of their male relatives, that might create a picture or a pattern on their family tree that there might be some sort of genetic predisposition to cancer. So we have again, another good thing that we have in Ireland is a system of family history clinics where patients, if they do feel that there is a family history of particular type of breast cancer, they can go to these family history clinics. They fill out a questionnaire. They're kind of screened to see if, you could be right, there might be some form of mutation there. And then if it is determined that these people are kind of at moderate risk or high risk of developing breast cancer in the future, they're screened more frequently.
And then I suppose there's the really insidious side of cancer that can get anybody. I mean, children, it's always heartbreaking. People who never smoked, never drank, exercise every day, and it's just can be so random.
Yeah, and unfortunately, that's the reality, and we do see that, a good bit as well. Where there are people, they've done everything right, and they still end up getting cancer. But the thing to say there, it's not that you can do everything right, and as a result, then be 100% guaranteed you're not going to get cancer.
Yeah,
there's lots of things we don't yet understand as to why some people get cancer and some people don't, and it's not always external factors or environmental factors or things that you didn't exercise enough, or you didn't eat the right food, or you drank too much, or you smoked too much. And if only you hadn't done all that, you wouldn't have got cancer. That's not the case. None of those factors on their own directly causes cancer. It's often that, like at a very cellular level, cancer is caused by abnormal cells that have just managed to escape the normal checkpoints that our bodies have, and they just grow and repopulate. And sometimes there just are environmental triggers or factors that kind of promote that or accelerate that, or make it happen. But there are other, a lot of it is intrinsic, and you just, some people unfortunately do get cancer.
and is that why then you would see cancer a lot in older people or over 65s, because that's the cells are kind of mutating or getting older, or they're less able to fight.
Yes, exactly.
And then the cancer can spread quicker. Is that how it kind of works on a very basic level?
It is, although the that is true. But as we get older, it's often the case that the cancers are kind of less aggressive or less serious as we get older, because our cells are just that little bit slower. They're probably less likely to grow as fast and spread.
Which is why, say, with something like prostate cancer, it's and I know this, just from very recently, that it's better to have a diagnosis in your older age than if in a man who's 45.
Usually, yes. Yeah, for
okay.
sure. Yeah. And they often find prostate cancer on men's postmortems that the man didn't even realize they had, and they certainly didn't die from the prostate cancer.
Can we talk, Lorraine, about the emotional turmoil of the diagnosis? Because, I, in the last number of years, with friends of mine who've been affected and my kind of wider social circle, guilt is a big thing. And that kind of what just like what we touched on earlier, was it what could I have eaten better? I should have exercised. I should have given up smoking before I did. And there's that sort of, that can really grow legs and is not helpful in any way.
No, I mean, I definitely think the most difficult time for people during the journey is probably, returning for the results of scans or biopsies, and people generally shouldn't be going to those appointments by themselves. They should generally bring someone with them, because whether it's good news, if it's good news, it's nice to enjoy that moment. But if it's upsetting news, a lot of the time, the only thing that patient is going to remember is, what did the doctor say? It's cancer. And then they may well forget everything else that's said after that. We know that, but we still have to provide patients with the information at the time, and we will repeat it again, obviously. But the emotional side of things is huge at the time of diagnosis. But human beings are amazing. I mean, they can take that information then and slowly come to terms with it and digest it and process it, and begin to move on then from the diagnostic phase into the treatment phase. I mean, it is amazing how people can actually cope with these things, for the most part. I mean, they do get support, and we do support them, but people are, I do think that's amazing when you just see people getting bad news, and, sometimes I'm nearly more upset than they are sometimes, the fact that we have to give this bad news, but then people can, process it and move on to the treatment side of things, which is in some ways a positive move, because at least they're getting their treatment and their options. And
well, it's a focus as well, isn't it? It's like, now we can deal with this. We will deal with this, and this is what's available to us. These are the outcomes. There's so many different options.
And the guilt side of things, that, when you're moving on to the treatment side, is less of a thing then. Because people often give up cigarettes then, they've just been diagnosed with, say, lung cancer, and they give up the cigarettes then. But, you know, sometimes that's the most, I'm not condoning continuing to smoke, but, you know, sometimes that's the most stressful period of time. It's probably the one time that they want to have the cigarettes, you know. And sometimes it's probably a bit late then to have made the decision to give them up when, you know, is it going to make a big difference now to quit smoking?
Yeah. And in a situation like that, I'm just thinking of somebody who's maybe newly diagnosed or their loved one has been newly diagnosed. What is the biggest piece of advice you would give to somebody in that moment? I mean, you've to deliver the news.
So I think the biggest piece of advice really would be, you are not alone in this. You know, you don't have to go through this alone. We're all there. We're there at the team to fully support people and to, I suppose, we kind of select the treatment and the language we use for that particular patient. So there are patients who, if they want every single bit of information in the most technical of terms, we have no problem providing that. And similarly, if you don't want to know anything about it, you just want to have your treatment and don't want to know anything about prognosis, that's fine. You know, we're not the Grim Reaper. We're not going to be telling you to, you know, to organize your funeral or anything like that. So generally it's to, you know, our advice would be to just take it one step at a time. It can be a long journey, like some of the treatment protocols for some of the more complex breast cases can be, you know, nearly a year of treatment between chemotherapy, surgery, radiotherapy, maybe more chemotherapy. So my advice would be to very much take it one step at a time as well. You know, deal with each treatment individually as opposed to be totally living for the end. I mean, it's okay to live for the finish date and all of that, but one step at a time.
Have you had, Lorraine, and I'm sure you have, patients that don't agree with your diagnosis or their treatment plan?
Yeah.
Because that's something that what I hear about a lot. People going to get second opinions, not comfortable, not happy, I suppose in shock, you know, and needing another avenue.
Yeah, no, we do get that from time to time, and that's totally okay. Like we do not take offense if someone doesn't agree with the treatment options we have given to the patient. And similarly, you know, I suppose we live in a world where there's a huge amount of information available, and some of it is factual, correct, scientific information, which is the sphere we work in. But there's lots of other information available as well, which wouldn't really be evidence-based or scientific. But, you know, if a patient does want to get a second opinion or feels that, you know, they want to be treated in a different way or don't want to be treated in the conventional way, that's okay. At the end of the day, you know, patients, they make the choice. They come to us for their treatment options. It's our job to be trained to know what the treatment options are and to advise patients about what we feel is the most appropriate treatment for them. That's our job, but it is up to the patient at the end of the day to decide what treatment they want to have. Most patients, you know, of course, following consideration and discussion with ourselves, do elect to go for the treatment we recommend and the treatment that this multidisciplinary team recommend. But for sure, yeah, we do encounter patients who, you know, it's not for them and they want to seek either alternative pathway or a second opinion. And they're perfectly entitled to do that.
And where do you sit in terms of holistic treatment or alternative medicine alongside?
So I suppose
medication?
I think it's complementary to you know, what I would say is conventional medicine. There are some treatments that we would disagree with.
Like what?
So, I mean, there are patients who I suppose elect to go, you know, abroad for stem cell therapy and spend a lot of money on it and are promised the world, but there's no evidence for this treatment in cancer, you know. And then they can come back to Ireland and, you know, a lot worse off than they were, both clinically and financially. And sometimes then they do decide to go down the conventional road. But there are a number of other certain diets that people are, you know, convinced to go on that will cure them of their cancer. There's no scientific evidence that these things work. But that said, it's not wrong to be on a healthy diet or to be eating healthy foods during your treatment. I have no problem with anything like that. None of the team does. But I suppose we do get concerned when people, I suppose, are kind of can I use the word brainwash, to go off on another path for something that's just not standard of care anywhere.
I mean, there's a lot of talk, and I'm working on a program at the moment, which I was telling you about, and it's about kind of aging and regenerative medicine. And a lot of people in that space would believe in Ireland we focus too much on medication and a kind of a treatment for people when they're sick, as opposed to focusing on kind of preventing people's health and preventative medicine.
Yeah, I think definitely there has been a lot more investment in public health awareness, in preventing cancer over the last decade or so. Okay, so it's not about, as you say, treating the cancer once you've got it. It's about preventing it from happening in the first instance. So I suppose there has been a lot of, campaigns, media campaigns to, reduce alcohol consumption and, being careful in the sun, using our sun, our SPF, and, eating healthily. So it is, I think it is improving, that emphasis on not just the kind of going into the doctor for your treatment, but preventing the cancer in the first place. But there's more to be done in that, I would say.
Yeah, 100%. Listen, our hearts are working 24/7, right? So if you do ever feel that worry, maybe some unexpected chest pains, palpitations, breathlessness, you need to know that there is also expert help available 24/7 too. That's why I want to talk about Matter Private Network in Dublin. They are the only private hospital in Ireland offering urgent cardiac care all day, every day. And I'm talking weekends, bank holidays, even in the middle of the night. Now that is genuine peace of mind. This is such a unique service for anybody who is worried about their heart. And if you're not sure, just pick up the phone and call them first. You can ring 1800 24/7 999. You'll be put directly through to a cardiac specialist nurse who will talk you through your symptoms. If they need you to come in, you'll get a thorough assessment immediately. If you need treatment or a procedure the same day, they'll arrange it straight away. It's about getting swift expert care from one of Ireland's leading hospitals. If you're worried about your heart, the number to save is 1800 24/7 999. For more information, you can log on to matterprivate.ie. Save the number and be prepared. AI, we are hearing about it every day. It's in all the papers. There's not a day that goes by that we don't hear about AI. And a lot of the time there's the negative that we hear. Yeah. But when it comes to health and health technology, this space is so interesting. And I know you work in terms of clinical trials. I know you do a lot of research and training doctors in as well. Are you excited about the future in that space?
Absolutely. I think AI is, for the most part, brilliant.
Yeah.
I mean, I use it myself all the time, just in my personal life, and even just looking up something quick. I think it's great. But I suppose you can see it makes mistakes. That so-called hallucinations. Sometimes you might type in something and or like one day I saw this lovely dress and I took a photograph and I put it into ChatGPT. I said, "Where's this dress from?" And it told me the wrong place. It makes mistakes.
Yeah.
But in radiation oncology, we have actually started using AI like quite a number of years ago. So like when patients are having their radiotherapy planned, it's all planned using this 3-dimensional CT scan. So if you're treating, say, the pelvic area, we do a CT scan of that region to design the patient's treatment. So that can be very labor intensive. That's our job, because we have to demarcate on the scan where the bladder is, where the bowel is, where the hips are, where the uterus is or the prostate is. And when I first started training in radiation oncology, that was probably the most labor intensive part of our job back then. That used to take hours. But now there is AI to do a lot of that for us. So the AI does what we call auto contouring. So it actually contours all these organs at risk, which are near. It doesn't contour the tumor, but it contours everything except for the tumor.
Wow!
Literally immediately,
in seconds.
Yeah.
Wow!
It's amazing.
And to think about where that's going to be in 10 years' time, and 20 years' time, it's phenomenal.
Yeah.
And you were actually involved in something, kind of when you talk about 3D imaging, in terms of breast prosthesis.
I was, yeah.
This is incredible.
Yeah. Well, it's a work in progress, Kathryn, to be honest. So a couple of years ago, I had a patient who was just finishing her radiotherapy, and she had had a mastectomy. So she'd had her full breast removed, and she was finishing her radiotherapy, and she was back to me for her follow-up visit. And she was doing really, really well. And I was examining the area just to make sure that any redness that might have developed had settled down. And I brought her into the examination room, and she whipped off her bra, and she had this really heavy prosthesis inside in her bra. So a prosthesis is like a fake breast, essentially, in a special type of bra, so that from the outside, no one really knows that this lady would have had lost her breast for cancer surgery. And I lifted it up for her. She's a lovely lady. I lifted it up for her, and I was like, God, that's so heavy. God, how do you carry that around? And she said, well, I'm only wearing it today, Lorraine, because I'm coming in to see you, but normally I don't wear it at home.
It's just too heavy.
Yeah, it's way too heavy. So a couple of days later, I was at a grand rounds meeting in University Hospital Limerick, where I'm based. And grand rounds is it's a great forum for doctors and the hospital staff to present their kind of what they're working on in terms of research, or it's an opportunity for a particular specialty to educate other specialties about what they like to do and nuances in their work. A guy from University of Limerick, Kevin O'Sullivan, was there, and he worked at the time for the Rapid Innovations Unit in UL. And the Rapid Innovations Unit is it is what it says on the tin. They do these rapid kind of fixes for patients in healthcare. So they were able to 3D print certain cutlery for a patient who had really deforming arthritis of her hands. So she was in hospital. She couldn't eat her food because she couldn't lift up her cutlery. So the Rapid Innovations Unit were invited to come along, and they designed amazing cutlery for her. So now I went up to this guy, Kevin, at the meeting, and I said, Kevin, I think we could collaborate, because I think that we could do better for these women and their prostheses. So he came over to me then a week later, and I showed him the prosthesis that this lady would have had, and I showed him the planning scan, the CAT scan that we would have done when we were designing her radiotherapy. So if you can imagine, she had no breast on one side, but she had the opposite breast was still there. So he was able to, with her consent, obviously, he was able to generate a 3D printed prosthesis, which was exactly a replica of her opposite breast. So that was kind of the first iteration. So then
weighing literally nothing.
Oh yeah, actually that one was probably too light. She still felt a bit unbalanced. So that was the first iteration then, and then we applied for funding by the Public Sector Innovation Fund, and we were successful in that. So then we were able to buy a 3D printer.
And
so
is this
amazing.
the first of its kind?
Yeah. So there have been 3D printed breast prostheses, available on the market for some time, but they're generic. So, it was literally like just buying a bra, like A cup, B cup, C cup, whatever, but they were not bespoke for that particular patient's anatomy. So when someone has had a mastectomy, like their anatomy is changed, like their rib cage is slightly changed, the skin is slightly changed. And, obviously no two breasts, no patient's breasts are the same. So this exactly replicates the opposite breast. So because it's 3D printed, so you basically scan the opposite breast, you flip it over then, and you 3D print the mirror image, and you get a breast that exactly is the same as the opposite one. Yeah.
Wow.
Yeah.
I mean, that's
like that was just a light bulb thing. I don't know. It was just one day I was just, we can do better.
That is a light bulb moment.
Yeah.
Is that what what would you say you are most proud of in your entire career?
What I really love is when patients come back for their final visit, 5 years, after they finish their treatment, particularly, I suppose, the gynae patients. So the patients who've had, treatment for cervix cancer or cancer of the womb, that's challenging treatment, like despite how far we've come in terms of success and cure and being, so precise with how we treat these patients, there is an aftermath. So it is lovely to get to the 5-year mark with those patients and to say, you don't have to come back to see me anymore. I suppose that's probably the most fulfilling part of my job,
You touched on cervical cancer there, and obviously we had huge scandal when it came to the cervical smears. Where are we now in terms of detection and the program running smoothly?
Yeah, we have a really good program here in Ireland. In fact, we always did have a very good program, but it has been made even better now, whereby we're now not only on smears looking for abnormal cells. So that's what was happening previously. Now we're looking at the cause of these abnormal cells, i.e. the HPV virus. So it's more like HPV screening now on smears. And, if you can detect the virus or the fact that the virus had been there, it means that you can then go down a certain line of follow-up so that you're much less likely then to even get the abnormal cells from the virus, not to mind the cancer down the line.
Down the line, yeah.
So we have, that has been a real improvement, I suppose, to the screening program. And I think public awareness as well has probably improved that, and I think there was an education piece there, I suppose, from their cervical check scenario, in that I suppose maybe people thought that, well, if my smear is normal, and yet if I have symptoms, but if my smear was normal, then that's okay. Okay. Whereas I think people now understand that irrespective of whether you have a normal smear or a normal mammogram, or, you've sent off a stool sample for the bowel check screening program, if you have a symptom that's persistent or abnormal, irrespective of what your screening test results have shown, that still needs to be investigated, So I think that was one of the good outcomes from the cervical check thing was, that awareness that screening isn't perfect.
The be all and end all.
It's not designed to be, It's screening the well population, and it's never going to find everyone, it's not designed in that way. But the good thing is, I suppose we have educated, I think, the population a bit more to, if you have something abnormal going on, your GP doesn't mind if you go and ask them about it.
Yeah. And of course, now we have the HPV vaccine as well.
Exactly.
And what's generally the uptake on that?
I think it's pretty high, to be honest. Again, initially at the start, when it was being first rolled out, there was a lot of maybe not even a lot, but there was obviously people kind of wondering, well, is it safe to be giving a vaccine to my teenager? What does it imply that I'm giving this vaccine to my teenager? But the evidence is overwhelmingly positive that if you can eradicate the HPV virus, you reduce the risk of cancer. It's one of the real good success stories.
And this is for boys and girls.
Boys and girls, yeah.
So you're a mom of how many kiddies?
I have 3 children. So I have 13-year-old, almost 14, and a 12-year-old and a 9-year-old.
Okay, and all will be getting the vaccine.
Oh, they will, yeah.
Yeah,
for
absolutely
sure.
Same,
for
same
sure.
100%. I just think it's an incredible...
Yeah, it's fantastic.
Life-saving.
Yeah.
Being an oncologist and a mom of very young kids, and you've had a really rough day and it hasn't gone the way that you'd hope for a patient. Like, I couldn't imagine getting into the car and driving home and making dinner and building Lego. Do you know what I mean?
Yeah, I do know what you mean. I suppose the thing about having 3 young kids is that it's all consuming. So you kind of don't really have the opportunity when you come home to start thinking about the sad stuff or the challenges that, we've had at work or that patients have had. But I'm very open with my kids, so if I came home someday and I'd say to them, God, I had a really sad case today, or I wouldn't be giving them the graphic detail or anything like that. It would be age appropriate, but I suppose we don't, myself and my husband, we don't really talk to our kiddies like they're babies, because they live in the real world. So if we come in from work in the evening, I would say, God, something sad happened at work today, and then we'd move on from it,
Okay.
So I kind of don't keep it to myself. I would just say it out, you know, as I said, without giving them the gory details. And I think they like that then,
And having worked the last number of years in the space that you're in, what are you most hopeful about for the future?
Well, I think I think we're in a good place in Ireland at the moment with cancer care. I really do. I think more and more people are becoming aware of the reversible things that they can do to reduce the risk of them developing cancer. But I also think that in terms of survival rates, We are improving all the time in most cancers. And I think we can be proud of all the technologies that we have now, all the targeted drugs that we have now, all of the very precise surgery that we have now, the multidisciplinary care. And I think the biggest thing is not only now are we, curing cancers, but we also have a very good survivorship program for, patients who have recovered and survived. And, there can be an aftermath for those patients. So that's been acknowledged now. Whereas I think previously the emphasis was on cure. And of course, that's really important. But there is an aftermath for patients, particularly people who are diagnosed, when they're younger, they can have problems with fertility and problems with their bowel and their bladder, or, if we've had to treat their brain, they can have, cognitive problems. So I think the fact that now in society and in Ireland, we acknowledge the fact that there are survivors living amongst us who, need our support. I think that's a really good positive development, is this survivorship program.
Yeah. And you just mentioned support there. I'd also like to give a shout out to the cancer support services all around the country.
They're amazing, yeah.
We have some phenomenal people, some phenomenal volunteers in every town in Ireland. I'm thinking ARC, I'm thinking Barristown, I'm thinking Laura Lynn, I'm thinking of all of the amazing cancer services, the Irish Cancer Society. There's so much help out there. So when you get that diagnosis first, you go, Jesus, and it hits you like a train, I'd imagine.
Yeah.
But then, as I said myself, having seen my best friend go through a very, very difficult time 2 years ago, the support and the help that's out there emotionally is unbelievable.
Absolutely. And when the patient is first diagnosed, they're getting all the kind of, the clinical, the medical, the info.
The emotional support is as important.
Absolutely. 100%. So in Limerick, we have the Midwestern Cancer Foundation, and they provide a huge amount of support. You can go for Reiki, and you can go to mindfulness talks, and you can go to, group sessions, you can go to counselling, and then you can do your fun runs and your money collection and all of that. It's amazing, and some people, it's not for everyone. Some people prefer to keep their healthcare stuff private. That's fine. But then some people just find that the support centres are just incredible, and they are. Even simple things like where am I going to park, or how do I get for my treatment each day? Like a lot of the patients that have to come for radiotherapy, there's not that many radiotherapy centres in the country. So they often have to have long journeys to come every day. So in Limerick, actually, we have a great initiative between where I work in the Mater Private in Limerick and the Cancer Support Centre in Kerry, where we have a bus that comes up and down each day for patients who are coming for their radiotherapy. And it really just makes the day easier, because people don't have to be taking time off work to bring their family member, and people don't have to be worried about navigating the streets and the motorway, and the bus is provided, and it's great.
It's amazing.
Yeah.
Listen, it has been so lovely chatting to you today, and thank you for kind of explaining it to us in very accessible language for me, first and foremost. But again, to kind of remind people that there is positivity
very much,
after a diagnosis as well.
Yeah.
Dr. Lorraine Walsh, thank you so much.
Thanks
for
very
coming
much,
into the
Kathryn.
Are We There Yet
Thank you.
studio.
Thank you very much.
Listen, our hearts are working 24/7, right? So if you do ever feel that worry, maybe some unexpected chest pains, palpitations, breathlessness, you need to know that there is also expert help available 24/7 too. That's why I want to talk about Mater Private Network in Dublin. They are the only private hospital in Ireland offering urgent cardiac care all day, every day. And I'm talking weekends, bank holidays, even in the middle of the night. Now that is genuine peace of mind. This is such a unique service for anybody who is worried about their heart. And if you're not sure, just pick up the phone and call them first. You can ring 1800 24/7 999. You'll be put directly through to a cardiac specialist nurse who will talk you through your symptoms. If they need you to come in, you'll get a thorough assessment immediately. If you need treatment or a procedure the same day, they'll arrange it straight away. It's about getting swift expert care from one of Ireland's leading hospitals. If you're worried about your heart, the number to save is 1800 24/7 999. For more information, you can log on to matterprivate.ie. Save the number and be prepared. You've been listening to Are We There Yet? Hosted by me, Kathryn Thomas. Visual design and video edit by Stephen King O'Farrell and Connor Daly. Music courtesy of Audio Network. Series producer Paul McGregor and executive producer Sasha Hamrogue. New episodes of Are We There Yet? Are released every Tuesday morning wherever you get your podcasts, and you can also watch this episode along on YouTube. Are We There Yet? with Kathryn Thomas is an Onyx original.